In this video, I'm going to talk about acute appendicitis. For introduction, acute appendicitis is the most common cause of acute abdomen, and the appendix is classically 7.5 cm to 10 cm. This picture shows the different locations of the appendix, which are retrocecal, subcecal, pelvic, pre- and post-ileal. So the more common ones are these four locations, where retrocecal is the most common site for appendicitis, where there is 75% out of the cases are at the retrocecal location. The causes of acute appendicitis are dietary causes, for example, decreased intake of fiber and increased intake of refined carbohydrates. Other causes include obstruction of the appendiceal lumen, can be due to fecal leaf, which are the calcium salts and fecal debris collected around the needles of fecal material within the appendix. Can also be obstruction due to lymphoid hyperplasia, which is associated with inflammatory disease like Crohn's disease and also other infective diseases. Some of the less common causes are obstruction due to parasites, tuberculosis, tumor, or foreign body in the appendix. For pathophysiology, so at first, it is caused by the obstruction of the appendiceal lumen, which is inside the appendix. This will cause build-up of mucus in the appendix, which later increase the appendiceal lumen pressure, and this will reduce blood flow to the appendix, reduce oxygen delivery, causing hypoxia, and later causing ulceration of the mucosa lining of the appendix. So when there is ulceration of the mucosa lining, this will promote invasion of the bacteria, which further cause inflammation and swelling of the appendix, causing acute appendicitis. So there are a few symptoms of acute appendicitis, which are mainly the four classical features, for example, migratory pain, nausea, vomiting, fever, and anorexia. And in some cases, there will be diarrhea or constipation. So migratory pain is a very significant symptom of acute appendicitis, where there is pain from the umbilicus initially, and then referred pain to the right iliac fossa, which is shown in this picture over here. So at first there is central abdominal pain at the umbilicus, and then the pain will be referred to the right iliac fossa, especially to the McBurney's point, which I will explain more later on. Okay, so for nausea and vomiting, it almost always occur after the pain. If nausea and vomiting is before the pain, it is more suggestive towards intestinal obstruction instead of appendicitis. So for physical examination, we can do inspection and take note of any limitation of respiratory movements in the lower abdomen to suggest for acute appendicitis. On palpation, we palpate the McBurney's point, which is the point 1/3 of the distance from the right anterior superior iliac spine to the umbilicus. So this picture over here shows the McBurney's point. We draw a line from the ASIS to the umbilicus, and 1/3 of the distance from the right ASIS will be the McBurney's point. And this point is very important because in acute appendicitis, there will be muscle guarding over that point, and also tenderness at McBurney's point, especially. And other signs include rebound tenderness, rigidity, and guarding of the abdomen, which can be noted during palpation. There are several signs to elicit in acute appendicitis, which includes Rothsing sign, obturator sign, psoas sign, and cough sign. So Rothsing sign is when there is deep palpation on the left iliac fossa. The patient will complain of pain at the right iliac fossa. And the second sign, obturator sign, is when there is internal rotation of a flexed right hip, there will be pain at the right iliac fossa. This is due to the spasm of the obturator internus muscles. Third sign is psoas sign, where there is right iliac fossa pain with flexed right hip. This is because the inflamed appendix is lying on the psoas muscle. So when the right hip is flexed, they will cause pain at that area. And the fourth sign is cough sign, where you ask the patient to cough, and there will be pain at the right iliac fossa. Okay, so next is Alvarado score, which can be easily memorized by using the mnemonics MANTRELS, MANTRELS. So this Alvarado score is important to help in the diagnosis of acute appendicitis. And it is divided into 3 groups, which are symptoms, signs, and laboratory results. For symptoms, there are 3, which are migratory right iliac fossa pain, anorexia, nausea, or vomiting. For signs, there is tenderness at the right iliac fossa, rebound tenderness, or elevated temperature, which means there's fever more than 37.5 degrees Celsius. And for lab results, there is leukocytosis or shift to the left of the neutrophils. So I've included the points for each symptoms and signs and also lab results. It's either 1 point or 2 points. And by calculating these points, if the total point is 3 and less, then it is unlikely to be appendicitis. If the total is 4 to 6, we would recommend a CT scan to make sure to rule out appendicitis and to diagnose. And if the total is 7 and more, we will need surgical consultation because high possibility of appendicitis. So the total point of Alvarado score, full marks is 10 points, and this is a quite useful tool to diagnose acute appendicitis. For investigation, we can do full blood count to assess the white blood cell count, which is usually increased in appendicitis. We can do renal function tests to look for any electrolyte imbalance, CRP to, if there is raised inflammatory markers, it suggests acute appendicitis, and also imaging like abdominal ultrasound or contrast enhanced CT scan to look out for appendicitis and also to rule out other possible diagnoses. So other investigations include pregnancy tests to rule out ectopic pregnancy because it might cause right iliac fossa pain as well, and especially in women who are in their reproductive age, we have to rule out this differential diagnosis. And another imaging to do is erect chest x-ray to rule out any perforation of the bowel by looking for free gas under diaphragm on the x-ray. So the management of acute appendicitis can be divided into medical and surgical. Medical, we advise patient for nil by mouth, give adequate hydration, and also give IV antibiotics. We correct the electrolyte imbalance, and for symptomatic relief, we can give antiemetics and analgesia for pain relief. And surgical management is the definitive treatment, where we do open or laparoscopic appendectomy. So that would be the definitive treatment. So that's all for my video. Thank you.